Welcome to our webinar. This is WFLHCA broadcasting this morning at 7 a.m. on 12/21, pre-holiday. We want to welcome my friend Nigel, Dr. Niwaz, who's going to be talking about plaque and possibly plaque regression. I was going to say a few words first about plaque progression. And actually, I like to call it something different. I like to call it plaque transcomposition, morphology, and functionality. And the equation for me has always gone from left to right. And so we've got genes and lipid pool. We've got macrophages, microbiota, but you'll find out more about that from Stanley Hazen from Cleveland Clinic when he comes here on May the 12th. And then we got inflammation, which is a huge contributory. All of this basically is leading up to necrotic core, which is like a blister inside the vessel, and we have examples of that down here. And necrotic core then goes to fibrofatty. This is what I consider the danger zone. And we got down here at the bottom, just to illustrate, we've got a 4-day before heart attack plaque, and then we've got a 188-day before heart attack plaque, and then over here is a 420-day heart attack plaque. All of them have rich lipid cores, and so various amount of occlusion and various amount of distance from the rich lipid core to the lumen of the vessel, and also various amounts of coalescence of the rich lipid core, but they all have that in common. Whether they have a thin fibrous cap or not is beyond us with CT, where you need to have computerized tomography imaging of some sort other than RCT X-ray. You need something that's more detailed to be able to distinguish the 65 micrometer cap from an 85 micrometer cap, and we can't do that. But then we go from fibrofatty to fibrotic and calcified, and then this may lead to an atherosclerotic plaque with severe blockage, but we have lots of warning usually with blockages, and when it's a severe obstruction, people develop angina. 25% of heart attacks are due to that. 75% of heart attacks are due to necrotic core lesions that are fibrofatty or fatty. And so I've always thought this was unidirectional from the studies that we see. We do see shrinkage of this as it goes from fibrofatty and necrotic core to fibrotic. You lose some water in the collagen and it shrinks, and as it becomes calcified, it shrinks too. So we've seen shrinkage, but we haven't seen what I would call true regression. We see progression or transcompositional changes. And so I'm interested in that, and we can show you some of the things that have been illustrated that seem to pertain to that. And it looks like that most of the pictures you see, they show that there's been a change, and the lumen was compromised and was 48% diameral lesion, and now there's a 49% diameral lesion, which is progression. Or they say there was a 47% diameral lesion. They said that's regressed. Well, it hasn't regressed very much. And so we could look at some of these pictures and see what we've seen with IVUS and so forth, and the wall shear stress. But let's see what Nigel has to say, because he's going to review this for us. Because there's been some things about, well, yeah, you put somebody on statin and it goes to calcification or it goes to fibrosis. Other people say, well, you put them on a low-dose statin and nothing happens, and you got to do really high-dose statins to get anything effective. And now we've got information on PCSK9. Is that helping? So let's take a look at what Nigel has to say, because he's looked at this and is going to try to summarize it for us. So I'm going to give you Nigel.
Good morning. My name is Nigel Niwaz. I am a third-year cardiology fellow at Northside Hospital in St. Petersburg, Florida. And today we'll be talking about lipid-lowering therapy and plaque progression, or I guess as Dr. Harrison puts it, transcomposition. So this is basically the progression of atherosclerotic heart disease, beginning early in life, from the progression for a lipid-rich core, eventually to smooth muscle and collagen, fibrous cap, and eventually thrombosis, causing acute myocardial infarction. This is basically a breakdown of the physiology. You have retention of lipoproteins, and that leads to recruitment of monocytes. And after that, you would have macrophages, foam cells, and this could be in a steady state where you progress to further worsening atherosclerotic and vascular disease, or sort of regression where you are able to remove these lipoprotein molecules that's associated with inflammation, as well as decrease in the macrophages and foam cells. So plaque regression is a highly dynamic process. Plaques are very responsive to the environment that they're surrounded by the stressors such as inflammation, as well as lipoprotein molecules. And a variety of processes are associated with plaque regression. So the first is removal of the lipid-rich core necrotic material by the removal of lipids and necrotic material to regional lymph nodes. And then you would have also restoration of the endothelial function. So these endothelial cells can repair areas of dysfunction, and furthermore, you would have vascular smooth muscle proliferation, which leads to narrowing of the lumen, but this process can also be slowed. So they will focus mostly on the lipid component and the inflammatory component. One of the first trials looking at examining atherosclerotic heart disease and luminal diameter versus plaque size was the reverse trial. This was published in JAMA, I think, in the early 2000s. So basically what they did was they had 502 patients that underwent angiogram. These patients were studied using IVUS. The patients had LDL from 125 to 210, so not at goal for patients with atherosclerotic heart disease. And they randomized them to either high-intensity statin with atorvastatin versus moderate-intensity statin with pravastatin. And the endpoints that they primarily looked at was change in the atheroma volume based on IVUS at approximately 1.5 years. And the secondary endpoints was change in atheroma volume and change in the percent of obstructed volume. Here you can see the changes in LDL, so mean LDL of 110 at follow-up in the pravastatin group versus 79 in the atorvastatin group. Total cholesterol was also lower in the atorvastatin group, and HDL was about the same in both groups. Change in atheroma volume, looking at IVUS, there was a larger change in the atorvastatin group versus that of the pravastatin group, and change in obstructive volume was also significantly different in the high-intensity group using atorvastatin. Percent reduction in CRP was lower as well, which is a marker for inflammation, and has been studied also in plaque progression, so significantly lower in the high-intensity statin group. So they concluded patients that were treated with high-intensity statin with atorvastatin 80 versus pravastatin had a larger reduction in lipid parameters, as well as change in atheroma volume. The study was not designed to assess mortality and cardiovascular events, and the follow-up was not long enough really for them to notice any significant difference between the two therapies in terms of events.
Yeah, Nigel, could you show me that slide again where it shows negative and positive, because I'm not sure, the other one just before this.
Okay.
Yeah, does this mean the plaque grew with pravastatin and that's positive, and it became regressed with the atorvastatin?
Mm-hmm.
And then on the right-hand side, the volume grew with pravastatin and with atorvastatin, but not as much with atorvastatin?
Yes, so
so the amount of regression was minus 0.4 versus progression. So minus 0.4 would probably be non-significant, it seems, as well as progression of 2.7%. Right?
Yes, correct.
Yeah, okay, good.
And after that trial, the next major trial was the Saturn trial, which looked at intensive statin therapy with rosuvastatin and atorvastatin. So Again, this study utilized IVUS to assess for plaque progression. Patients were followed for approximately 2 years, and the primary endpoints was percent in atheroma volume, and the secondary efficacy endpoint was total atheroma volume. So this is the baseline characteristics and change of statin therapy for both atorvastatin and rosuvastatin. So LDL mean was around 120, and there was no statistical significance between the two groups. On statin therapy, however, there was a significant reduction in both groups, 70 for atorvastatin and 62 for rosuvastatin. Non-HDL cholesterol, which is probably a better marker for better marker than probably LDL because it encompasses all the molecules associated with atherosclerosis, also was significantly lower, from 95 and 88 for atorvastatin and rosuvastatin respectively. C-reactive protein was also decreased, and there was a post-hoc analysis of this study, which I'll be talking about, looking specifically at CRP. So LDL levels, I mentioned, lower for both groups, and it was statistically significant. There were also higher levels of HDL, and the percent of atheroma volume decreased by 1% and 1.2% for atorvastatin and rosuvastatin, respectively.
So the percent volume decreased. The difference was 0.22%.
1.22.
Well, let's see. It decreased
For
almost 1%
for
with this one and 1.22% with this one. So the difference would be, the delta would be 0.22%,
Yes.
right?
Oh, between two, yes.
Yeah, that's not much difference, 0.22%. P-value is 0.17.
Yeah, so it's not
Okay.
significant.
Are you going to see me bouncing around here playing the devil's advocate? Thanks.
Yeah, so it was not. There was no statistical difference between percent atheroma volume between the two agents, and then the normalized total atheroma volume was lower in the in the rosuvastatin group. So basically, both agents were able to induce regression or transcomposition in a majority of patients. And this is a graphical display looking at the change in total atheroma volume. So it was statistically significant from where they started to for each agent, but the difference between the two was not statistically significant. And again, here, this is a result showing percent atheroma volume and total atheroma volume. There was no statistical significance between the two agents at baseline and then again at 2 years out. Data does suggest that females may benefit more from rosuvastatin as well as diabetics, looking at the whisker plot. And again, the study was not powered to detect any major differences between the two subgroups in terms of adverse cardiovascular events. Essentially, there were no major differences between the two in terms of non-fatal MI, stroke, revascularization, etc.
What was the total MACE for each one? Total MACE? You gotta add up the percentages.
Yeah, I think it came out to be like total was like 2% or something like that. It was not very high. So they conclude that maximum dose of.
Go back. You can add up the MACE. All these would add up then.
7.
First major cardiovascular death, non-fatal. Well, this would be included in that one, wouldn't it?
Mm-hmm.
So it looks like 9% or something, maybe. 9% MACE.
Yes. And then the maximum dose of atorvastatin and rosuvastatin both reduced HDL non-HDL cholesterol. It was a regression after coronary atherosclerosis. Both agents were pretty much similar in their ability to reduce atherosclerosis, with a small difference in total atheroma volume for rosuvastatin. So the changes were pretty much similar for the two agents. And then there was a study that actually looked analyzed the data from the Statin trial and specifically looked at CRP levels to associate if the inflammation was probably a better prognostic indicator versus LDL. So looking at the hazard ratio for major adverse cardiovascular event on treatment with CRP, looking at CRP, there was a difference in the statistically significant difference in the p-value looking at patients' CRP levels as opposed to just looking at which agent they were on and atherosclerosis. And then if you look at the quartiles from the first and the fourth quartile, there was a difference on the Kaplan-Meier curve in terms of major cardiovascular events. So the lower the CRP was probably a better predictor than LDL for progression of plaque and major cardiovascular event.
There's your 9%.
Yes. Yeah. Yes. So they concluded changes in LDL and CRP correlated weakly, and decrease in CRP was independently associated with plaque regression. And there was also a statistical significance in terms of CRP levels and major adverse cardiovascular events. Individuals that were treated with statin achieved both low CRP levels and LDL cholesterol levels had better outcomes, and systemic inflammation probably plays a more important role in plaque progression as opposed to LDL levels based on the study. And then this is a study that Dr. Harrison actually showed me, which was looking at statin levels in terms of looking at statin therapy and atherosclerosis in patients that underwent coronary angiograms. So IVUS has been regarded as basically a standard for quantifying coronary plaque, but that's obviously invasive and not preferred in a lot of patients, especially in patients that have non-ischemic cardiomyopathy. So the study looked at CT and looked at luminal narrowing, analyzing plaque, specifically also low attenuation plaque, which is defined usually as a Hausfeld unit of 50 to 60, and these plaques are also much more high in lipid content and probably more and a lot more vulnerable and have an increased risk for adverse events. The study was performed in China. It enrolled 206 patients that were suspected of having coronary disease and followed them after their initial CAT scan. These patients were statin naive, which they defined as no statin therapy for more than 3 months in the last year, or patients not treated with any lipid-lowering therapy in the last 4 weeks. Patients were from age 18 to 80, and they looked at lesions that were mild and non-obstructive, defined as less than 50% of the lumen. And the plaques that they specifically looked at were non-calcified plaques. Patients that were excluded were those with poor image quality. And the 3 groups of patients that they analyzed was patients that were on intense statin therapy, defined as rosuvastatin or atorvastatin, which both lower LDL greater than 50%. The doses that they used, though, were a bit lower than what we consider to be high-intensity statin. So instead of 80 of Tortiv, they used 20 to 40, and instead of 40 of Restuva, they used 10 to 20. Then they also looked at moderate intensity statin with lower doses of atorvastatin, rosuvastatin, fluvastatin, and simvastatin. And the third group was patients that were not treated with statin therapy. Follow-up scans were performed for approximately 1.5 years.
Okay, so these are people that presume to have coronary artery disease, yet we got the age between 18 and 80, so I can't imagine the 18-year-olds being presumed to have coronary artery disease and getting coronary CT with radiation exposure.
That's a good point. Um, and baseline characteristics between the different subgroups were essentially the same. There was no real statistical significance between um, ages with a mean age of 57 to 58 and LDLs of 127 to 135. Yeah. It was,
This is worst group. That's funny that you would have this group would be the worst group, and they're getting moderate. These are the best group, and they're getting intensive.
yeah, it was an observational study, so it was dependent, I guess, on the primary care provider.
Look at this smoking, diabetes, double. It's kind of amazing, isn't it?
Yeah.
Go ahead.
And looking at from baseline to follow-up, so LDL change of 135 to 63 in the high-intensity statin group, and LDL of 128 to 92 in the moderate-intensity statin group, both statistically significant. No significant change really in the patients that were not treated. Then looking at outcomes, so low attenuation plaque volume was significantly different from baseline to 1.5-year follow-up for the intense statin group as well as the moderate statin group. And no real significant change, maybe a little increase in patients that were not on statin therapy. Total plaque volume was also decreased in the intense statin group versus that of the moderate statin group, and this change was statistically significant. And percent plaque volume was also lower in the patients treated with higher doses of statin therapy versus patients with moderate statin therapy. And they applied a linear regression of changes in total plaque volume and low attenuation plaque volume, and as low attenuation plaque volume correlated with the change in total plaque volume. There was also looking at changes in total plaque volume versus the size of the plaque, and there was also on linear regression a decrease. So changes in total plaque volume with intense statin therapy was statistically significant and lower in the intense statin group, as well as change in percent plaque volume.
Do you have any pictures to show from this?
They didn't have any pictures in the study.
So recently we've decided that we're going to be doing some work with Watson, with the IBM computer, in terms of plaque analysis. And so in doing that, we have several responsibilities. One, we've got to curate the data, which means we create what's a corpus of data that comes into it, and we have to decide what we're going to put in and what we're not going to put in, and to do the same thing on bibliography. And so in analyzing this study, this is a study that I will put into Watson, because you see the hypertensive, the moderate statin group has more hypertension, has more hyperlipidemia, has twice as many diabetics, has more cigarette smoking, which is very common in China. And so there are lots of reasons why and there are no pictures involved, and Watson's going to be involved in imaging and looking at imaging and analyzing images. And so this will be one that, as a curator, I'll make the decision not to input this data because I think the data is kind of soft. The other thing is, what we're talking about here is we're talking about reduction of plaque volume, and what my interest in is the transcompositional changes. And so what I see as we go from lipid core to we go to fibrosis, you lose water in the collagen, the scar shrinks, and then you get some calcification. And I see those changes as transcompositional, and I call that progression rather than regression in terms of what's happening within the plaque.
So major study limitations were, this was obviously not a randomized control trial. Patients that were, that had probably more higher plaque burden probably were treated with more intensive statin therapy. The follow-up duration was not long enough to really assess for adverse outcomes. It's unknown if there are other confounders that they did not really adjust for. They will be doing longer follow-up on the current cohort. This article actually came out fairly recently, looking at evolocumab, which is one of the newer PCSK9 inhibitors, and atherosclerosis with IVUS. So I just want to go over the PCSK9 because I feel like they're still probably fairly new. A lot of primary care physicians are not familiar with them. So there are two agents approved by the FDA, which is alirocumab and evolocumab, both monoclonal antibodies. So the physiology of how these agents work is that LDL is taken up from the serum from with the LDL receptor located in the liver. If the PCSK9 complex is attached to this LDL receptor, both of the receptor and the PCSK9 is taken up into the liposome and degraded. If the PCSK9 is not, this molecule is not attached to the LDL receptor will then take in LDL molecules, and then that specific receptor would then be recycled. So the monoclonal antibody basically inhibits the attachment of PCSK9 to the LDL receptor. Therefore, you would have more LDL receptor to take up LDL molecules, take away LDL molecules from the serum. So both agents are approved for patients with heterozygous FH and for patients with clinical atherosclerosis who require additional lowering of LDL, currently on maximum tolerated statin therapy and possibly a statin agent. Evolocumab is, however, only the only agent approved for homozygous FH. And the Oslo study looked at evolocumab, and you can see that there is greater than a 50% reduction in LDL versus standard of care. There's actually another agent that's on the horizon probably in a couple of years, which is a RNAi inhibitor. And this agent was also showed around a 50% reduction in LDL and a 74% reduction in PCSK9 levels. So back to our study. So background, basically, no studies have really looked at any other agents besides statins in terms of plaque size and atherosclerosis. And LDL levels greater than lower than 60 hasn't really been assessed in terms of plaque remodeling. And no one's really also looked at PCSK9 level with the addition to statin therapy and what exactly would happen with atherosclerosis and plaque size. So they looked at 968 patients. Initially, I think they enrolled close to 2,000 patients, but a bunch of them were excluded for various reasons, and they looked at patients that had that were treated already with statin therapy with LDL greater than 80 or 60 or 80 with additional high-risk features. And patients were analyzed using IVUS and randomized to either statin monotherapy or statin plus evolocumab. And patients were followed for 78 weeks. So primary efficacy endpoint was change in percent atheroma volume, changes in total atheroma volume, and the proportion of patients that had reduction of percent atheroma volume and any reduction in total atheroma volume from baseline. They also looked at incidence of adjunct events such as all-cause mortality and changes also in lipid parameters, specifically looking at patients with LDL less than 70. So this is baseline characteristics of patients that they looked at. So baseline statin use close to almost 100%, and 60% of those were on high-intensity statin. Baseline LDL was also less than 100, which is lower than the previous studies. So mean exposure of evolucumab to these patients were around 18 months, and at the time of randomization, 58% were already receiving high-intensity statin therapy, and during a 76-week sub-treatment, the mean LDL in the statin group was 93 versus the evolucumab group, where the mean LDL was 36. And this graph demonstrates that. So early on, these patients were already on statin therapy, LDLs in the 90s. No significant change really, it was 3.9% increase versus patients in the evolucumab group, where the mean LDL dropped from 93 to 36, a 60% reduction. And looking at their primary endpoint, which was percent atheroma volume, there was no significant change in the statin group versus the evolucumab group. There was a huge decrease. And again, change in total atheroma volume, no significant change in the statin group versus close to 6% in the evolucumab group, which is also statistically significant. Statin monotherapy, there was no real change between the patients that had increased or decrease in the atheroma versus patients. There was a larger percent of patients in the evolucumab group that had a regression versus 35% had progression. Looking at patients that were already at a baseline of LDL of 70, patients in the statin group didn't really change. It actually went up 16% versus close to a 60% reduction with a mean LDL of 24. So basically looking at patients that were already on guideline-directed LDL goal of 70, so a huge decrease in patients that were getting evolucumab. And looking at those patients and the changes in change in percent atheroma volume and change in and percent of patients that had regression, much more in the evolucumab group versus the statin group. And again, here you can see there was a statistical significance in change of percent atheroma volume in the evolucumab group versus the statin group. And post-hoc analysis of the data showed that relationship between LDL levels and percent atheroma volume. As the LDL as the LDL levels decrease, there's a change in atheroma volume starting around 90, and as you keep going down all the way down to the 20, you'll see decrease in the atheroma volume. And this data sort of goes along with previous data from prior studies. So the Saturn trial, which looked at atorvastatin or stuvestatin, which we spoke about, the Illustrate trial as well as the Asteroid trial, showing that change in atheroma volume is associated with lower LDLs. And then looking at subgroup analysis, patients, diabetics, patients with baseline non-HDL greater than the median benefited more. Females tend to benefit more, favoring evolucumab. There was no statistical significance in the outcomes, but coronary vascularization and major cardiovascular events were lower. Concerns from statin groups were, from prior studies, looked at neurocognitive events and new onset diabetes, which is probably around 10% for statins. These patients had no statistical significance between the two. So conclusions that they were able to draw is patients that were getting evolucumab, you were able to achieve very low LDLs into the 30s versus 90s in the patients in the statin. There was a regression, or I guess transcomposition, in percent atheroma volume in the evolucumab group versus that of the statin group. And the changes were much greater in the evolucumab group. So there's probably benefits to lowering LDL beyond the current guidelines of less than 70 in terms of decreasing plaque size. There's also one study looking at, I know we talked a lot about medical therapy, but there's also studies looking at diet, and this was based on a animal model using rabbits, and they looked at 10% flaxseed supplements, and they showed that there was using flaxseed supplements, there was a 40% reduction in plaque formation. So maybe there is a role in flaxseed for decreasing atheroma volume. So for final thoughts, there's substantial evidence in medical literature suggesting that statins decrease mortality and also cause plaque regression or transcomposition. CRP may be a useful marker, but most of the studies have really looked at LDL levels, which is pretty much what most of the guidelines use for goal-directed therapy. Optimal LDL levels may be lower than the current guidelines of using 70. And there have been studies looking at not just mortality, but for example, the Miracle trial looked at LDL levels, and if you plot LDL levels and events, the lower the LDL levels are, the lower the events. And this goes along with that, showing that lower LDL levels is also associated with smaller or associated with plaque regression. And thank you. That was just a brief summary of the literature.
Okay, thank you, Nigel. So let's go back a little bit and talk about this. These are rabbits, and the rabbit model, basically you have to give them a diet that's very bizarre for a rabbit in order to get their cholesterol up, and then that doesn't do it. That will not cause atherosclerosis in the rabbits. You got to do something else, and so they got to do some kind of stress, and whether they keep them up all night with lights or bang on their cage. I don't know what the anti-vivisectionists have to say about that, but the rabbit has to have some stress and trauma to get that, and then they give them Bloxy oil, and then they look and see how their changes. And so the rabbit model is not a very good model for us, although it's it's a basic model for a bench laboratory. It's not a good model for us. I'm not much for the rabbit model, and so I don't know what to say about that. Certainly going back and looking at some of these other studies, that we certainly saw a great effect using the monoclonal antibody model to decrease LDL cholesterol, and it certainly does that quite well. It's really hard for us to measure major adverse cardiac events now because the rate of major adverse cardiac events has dropped from that first study you showed where it was 9% to 3% now. And if you use cardiac CT in managing patients, which you put them in different buckets, then you can drop it by another half, which takes you down to 1.5% major adverse cardiac events. And so if you have 1.5% MACE per year, then whatever you calculated for your study for either the number of patients or for the length of time of the study has to be changed. Because if we were counting on having a 9% and we got a 1.5%, then we've got to do either 6 times the number of years you've calculated or 6 times the number of patients in order to be able to produce MACE and look at a substantial amount of MACE. And so all our calculations have screwed up on the PROMISE study. They've screwed up on several other studies. There's a radiology study. All the things have messed up because we don't have enough MACE. So when we get at the end of the trial, as we have projected it, and only have 3% instead of 9%, or if it's a CT trial, we have 1.5% instead of 9% per year, then we don't have much to talk about at the end. So we talk about some gibberish stuff because we can't look at MACE, which is the endpoint. In this particular thing, there was 968 patients, as you see. We're at 423 and 423. And so the period of time, what was the period of time on this one? 78 weeks, which basically was not quite 2 years, a year and a half. So for a year and a half, and we've got 800 patients. Let's just call it 1,000 patients. You had 1,000 patients. You're expecting, and these are getting monitored with intravascular ultrasound, so it's cardiac cath, right? And so we've got cardiac cath, which is going to tell us pretty much about CT. It's going to drop MACE because we're going to put people in buckets, and we're not going to be working with patients that are normal or have minimal disease. And so the MACE will be about 1.5%. So in a year, you'll have 1.5 patients. There'll be 10 patients. We'd have 10 patients in a year, and then another, so it'd be 15 patients would have a major cardiac event, which would give us to 7 patients in each group, which is not much to be able to rely on in terms of making decisions. And so MACE is not going to be valid in such a short trial as this with such a low number of patients. And so we're going to really have to change our expectations. And so what are we monitoring? Monitoring plaque. Well, that's a good idea then, to start monitoring plaque with studies. And so I'd like to see monitoring plaque more with CT because we know quite a bit about plaque, and it's a lot easier to do than to do IVUS, which is takes some risk. You're inside the vessel and so forth. And so I still think a lot of what we're looking at is transcompositional, where we're basically, and we can show you some of our plaqueograms where actually we're monitoring patients and we find a plaque that's interesting and we follow the plaque over 3 years or 2 years or a year and a half, and we look at the plaque and compare before and after, and we can show fairly much that we're not seeing any regression on anybody. Maybe it's because we're not being aggressive enough in our statins. We're not seeing any aggression and regression, but we are seeing transcompositional changes where the plaque is going from a juicy plaque to a more fibrotic and calcified plaque. And then we've had people that have calcific plaques that we follow over 12 years, and we look at that, and the calcific plaque is unchanged in 12 years because it's an inert, neutral, focal calcific plaque. It doesn't have anything in it that's lipid or that's juicy. It hasn't seen a lipid for 12 years for some reason. And these are patients that are one and done. I believe that those are people that don't have the inflammation that other people have. So let's end this show. We'll go back to our transcompositional theory. And so basically what we're thinking, looking at these patients, is, again, the genes, the lipid pool, macrophages, and inflammation probably being the same thing. The microbiota, which you'll find is very important in terms of metabolizing L-carnitine and phosphatidylcholine to make TMA, which is trimethylamine. Trimethylamine goes to the liver and it's oxidized, and you get TMAO, and then TMAO actually is involved in the arterial wall, and you can actually measure the amount of TMAO, the arterial wall, and then that goes into necrotic core, fibrofatty, and so the direction being in this direction, the plaque is regressing because the plaque can get smaller as you go into fibrotic, and then calcified it can get even more smaller. And then when you get the nidus of calcium, as time goes on, the calcification grows because it's something for hydroxyapatite to precipitate on. And of course, there's some positive remodeling that happens a lot of the time. And so that's what we're seeing more of. And we can show you some other slides that describe that. Let's take a look at, here's a gentleman who had a calcific plaque that we have a picture of from 12 years ago, and we have a description, which is in the left anterior descending at the origin of the first diagonal is a focal calcified plaque. No evidence of any lipid core plaque, no fibrofatty plaque. This is it. This gentleman, his mother had a heart attack and died, and so he came and wanted to know what to do. He couldn't tolerate statins, so we said, well, just exercise and eat lots of fruits and vegetables, and so that's what he did. 12 years later, he comes back, and we find the exact same plaque that we described 12 years before that on coronary CT. No change, no new lipid core, no new plaques, and so we're calling these people one and done, and we're thinking this patient, by erosion, has a less than 1% chance of this calcific plaque eroding into the endovascular surface and causing a cardiac event. Well, here's a patient with a plaqueogram, and basically this gentleman is 31 years old. He's in the military. He's got this plaque that's on the septal side of the left anterior descending, and it's a linear, looks like a staple, the way it's so linear. It's positive remodeling, 31 years of age, and basically we tracked him at age 33. We did this thing called a plaqueogram. This was a regular heart, done with about 3 millisieverts, which is the same as background in a year, using step and shoot, I-dose, iterative reconstruction, and reducing the radiation. So, and this was probably, with a 64 slice scanner, was about 5 slices. So we identified the plaque of interest. There were no other plaques. So there wasn't anything else to look at. So we said, why do we want to look at the whole heart and all the arteries? Let's just take the plaque of interest and take a look at that and do the so-called plaqueogram, where we do one gantry rotation, just one gantry rotation, and pluck that out. And basically here it is. And since there are 5 slices and this is 1/5 of a slice, then this is 1/5 of the radiation exposure that the patient had before, which was less than 3 millisieverts. And so that's pretty low radiation in order to be able to get this in a 33-year-old guy, since we don't want to expose his chest to too much radiation. So we got this and we compared it, and look, it's exactly the same. There is no change from this study to this study on this plaqueogram. And so this gentleman, I believe this is non-atherosclerotic, because I can find some areas of calcification elsewhere in his chest that if I plot them and as points, I can see that there could have been a concussion wave that could have produced by trauma injury to several areas to produce calcification. So I don't know, this gentleman's lipids are normal, so I don't know why he has that, but I don't think it's atherosclerotic. But let's look at somebody else that does have atherosclerosis. And so this is an interesting guy. Here's someone who is in their 50s and who has, the first plaque was 56% diameter stenosis. Okay, the total plaque necrotic core was 34%. The fibrosis was 46%. Calcification was about 20%. Okay, that's at baseline, and here's the picture. This is the whole heart. So we said, this is a plaque of interest. Let's see what we can do with this guy. He can't tolerate statins. His inflammatory markers, which is something called the pulse score, PULS, which has now been released by Cleveland Heart Lab, along with the Tamayo test for microbiota effect, basically is available. And his pulse score was 1.22 times normal. And I'm not really interested in unless it's 5 to 6 times normal. So I don't think he has a lot of inflammation going on. This inflammation is actually measuring macrophage migration with indices and measuring apoptosis markers. And so there are 7 markers that are involved in this. So he couldn't take statins. So he does 25-pound weight loss, which is pretty good for a guy, 65 minutes a day on the treadmill, walking uphill, dropped his hemoglobin A1C from 6 to 5.2. We don't have lipid measurements. This is all we have. And so let's see what happened to him in the face of a year. So we measured at the same plaque, the same degree of stenosis, the same total plaque composition, and we were able to come up with this information. The diameter stenosis is 55%. Well, I would say that's no change, right? Okay, total plaque, necrotic core, not just the plaque measuring necrotic core at the stenosis, at the greatest stenosis, but the total plaque is down about 10%. Okay, the fibrosis is down about 10%. Okay, the calcification is up, well, guess what? 20%. Well, that's 10%, and 10% is 20%. So here's where it all went. It all went to transcompositional changes to actually calcific changes, a lot less necrotic core, less fibrosis. And so I think this is supportive of what's happening in terms of people doing a transcompositional change over time. We can show another one over here. Now here's a great example. Let's look at this one. Here's somebody who had 38% necrotic core at the stenosis site, which is we're worrying about the stenosis site because that's where the maximal hemodynamic effect is taking place, and that's where we have pressure on the shoulder, both proximal and distal shoulder of the plaque. We've got all kinds of hemodynamic reflective waves vortices and eddies that are eroding the plaque. And so to drop that from 38% to 7%, I think is a really significant change over a period of 2 years. That's right at the necrotic core. So nobody's talking about the necrotic core at the stenosis site, which I think is the most dangerous place. They're talking about total volume, total burden, and total volume of plaque, total volume of necrotic core. So I think we need to zero in on where is harm's way about to be approached and how can we prevent that. And so if you're interested in preventing rupture, that's where you need to act. Necrotic core of the entire plaque, well, look, it dropped by half. That's cool. Diameter stenosis has increased, and the cross-section area has increased. So we can just look at that plaque and see, look, there's less necrotic core, there's less red stuff, there is a smaller lumen, and there's more fibrosis, which is the blue stuff. This is all color-coded. And so, and of course the lumen is the green where we color-coded the contrast. Looking at calcium, we don't have calcium measured here, and this yellow is not calcium. This is actually a bleed over. It looks like a calcium halo around the lumen. Well, that would be very protective, and that would be a very nice thing to have, but that's not what's happening. This basically is a bleed over of the color green and the color blue, making the color yellow, and basically is an artifact produced by this particular software. So this plaque is much less dangerous, and I have much more confidence in this person developing angina before they have a cardiac event, and the cardiac event rate being lowered from 75% to 25%. And so that's a good thing. And when we look at this, I was visiting with the patient's doctor and the patient, and we were showing him the changes. And I said, I would think at this, at maximal exercise on the treadmill, you would be having some chest discomfort. And he said, yes. How'd you know that? And the patient's doctor said to the patient, you're having angina? I didn't know that. And so here we are reading the plaque, and we're telling the patient clinically and the doctor clinically what's going on. Isn't that interesting? That's a real tail wagging the dog here. This is an example of another kind of plaque there, where we have defined a bunch of plaque in this patient in September 2015. Patient has an episode of chest pain that occurs on Super Bowl Monday, and on Thursday he comes in to see his doctor 4 days later, and his troponin is negative, B-type natriuretic peptide is negative, his echo is negative, his EKG is negative. So normally you would say, oh, you had a severe episode of chest pain, everything's fine, don't worry about it, but I am worried about it. And so we did survey his plaque, and his plaque of interest was actually down here. But since he has plaque diffusely, as opposed to the other people I just showed you, we surveyed his entire LAD, and we did a CTA of all of his coronaries, and then we compared them millimeter by millimeter, and you can see we lined them up pretty much. They look pretty close to one another the way we've lined them up, and you can see, calcific plaques as fiducial markers. That's a word they use. Fiducial markers is a boundary word that's used by engineers. I thought of fiduciary having something to do with money, but it's fiducial, and they use that to basically show the markers. And so these are the markers, and you can see they're very similar. And there's been a rupture of this plaque here that's changed everything in terms of, you can see that there's a lot of necrotic core in there now. And so because of that, we were able to come up with a diagnosis of ruptured plaque. Have you ever made that diagnosis in somebody who didn't have a cardiac event? So we came up with the diagnosis of ruptured plaque, and we loaded him up with what you would consider very aggressive dual antiplatelet therapy, as well as high-dose statin therapy, and nothing happened to him after that. We believe that we could actually show, and we'll have to do that. We'll have to make another picture because it's time now, and we could show that we probably have stabilized that plaque. So we'll bring him back after a year and make another plaqueogram right in that area to see what's happening to that plaque with low radiation. We don't have to worry about radiation if we're just doing less than 1 millisievert informational CT. So these are some of the works that we have been doing that have actually challenged us to want to do more of this kind of work and to do more evaluation. Here's where we're looking at a plaqueogram. This particular patient trying to see progression. There's reduction in the necrotic core. there looks like the stenosis is about the same. And we could do this on this one. Here's one, somebody that we felt like we needed a stent, and so on and so forth. And these are the changes that people are observing, you know, where, yeah, there is a loss of volume, but look, there's more stenosis. We're seeing more stenosis, loss of volume. Looks like a loss of remodeling on this particular vessel. I can't imagine that, because I don't think that deformation goes in the other direction in terms of remodeling. So, but these are the pictures that people are showing, and here's a picture that someone is showing. Again, just like the one I showed you, no necrotic core, more stenosis, and basically a more stable plaque. That's going to result in warning and angina rather than a sudden cardiac event. So thank you very much for attending today. Next week, we're not going to have a conference because of the holidays between Christmas and New Year's. We'll send out an announcement to let you know, and our next meeting will be next year. So see you next year. Thank you so much. Bye-bye.